invite the other panellists to come up to the front. Now that the Brains Trust is in place, it's really going to be an open forum for any questions or comments that we might have, and again encouraging those who are online to please feel free to text in. I think this must be the only Poche Key Thinkers forum that we haven't had any online questions. So that's the challenge for the guys out there. Look, I think there was a really good question about sign language, and just in the last probably 6 or 8 months, there was a whole lot of discussion about Aboriginal Sign Language as distinct from Auslan and other language that's around, and particularly up in the top end of the Northern Territory, along the coast there. So I guess that's an issue that we really need to explore a lot more as to whether and how sign language is going to be a medium for education. We haven't touched a lot on education and early years education so far this morning, but there are groups out there that are working very closely with communities. I know one of the groups I'm involved with, the Australian Literacy and Numeracy Foundation, and we work very much from a speech pathologist perspective of engaging in those very early years and getting people not exclusively with hearing loss, but just getting exposure of parents and young kids into learning those words and the number of words that they need to have command of before they even set foot in a preschool. And and so the books in homes programs, the reading programs and so forth are so important, but it's how do we engage people? So I guess, are there any other thoughts or comments on the sign language question that was there?
I just like funny stories. The TWAV, and hopefully don't correct me because I really enjoy the story, is I do a lot of cochlear implants. I always try and encourage my patients to also learn Auslan. My sign name is King Kong, for all the kids to look after him. But one of the ones I enjoy the most is the sign for Australia, which people think is a kangaroo, but I think the origin is actually where they dumped all the convicts. Is that correct? But sorry, but it's a question. Signing is very, very important. I think education is important, and it's fascinating how many kids pick up sign and their own sign when they're not hearing naturally on visual cues particularly, and then they learn their own words and learn their own language. But I think it's very important that is translated. I don't think we're doing that well. And I think one of the downsides of implantation is that because implantation works so well, they're dropping sign. I'm trying to resist that as much as possible because it's really a sad kind of indictment, particularly if the implant's off or not working, or they lose their language straight away.
Are you finished? Kelvin and I were both recently on the National Hearing Roadmap Committee, and there was representation there from the signing deaf community. And I understand more now that the pathway to learning sign in Australia, or at least in certain jurisdictions in Australia, is actually quite a difficult one. So if a family wants their child to learn sign, it's not always easy to do that. So I think in general, the pathway to learning sign for children with hearing loss is not necessarily straightforward. But I think Carmen made a really good point, that languages also enshrine cultural knowledge. And we see, well, I see when I'm working in remote, that sign is a living part of everyday life. And I think it's incredibly important for children in communities to be exposed to that, and to be exposed to their community sign that enshrines community knowledge. So I think that's a really good question, good topic to discuss.
It's interesting, my 33-year-old daughter is learning Auslan at the moment. She wants to practice professionally. And incidentally, when she looks after my almost 12-year-old, she teaches her sign and they're having great fun together. But I wonder if we can think about the other side of the benefits of sign. And in a sense, I think you're talking about remote communities, Tom. You see this in remote communities, the use of sign. I guess in every hunter-gatherer society around the world, sign is a very important element for going about your business. But I think one of the side effects, which we could perhaps think about in terms of the non-Aboriginal and Torres Strait Islander elements of our workforce, is about, we mentioned Dejiri and deep listening, Uncle Lewis and his idea of doublies and the way we're seeing things. And it's a difficult concept for many non-Aboriginal people to grasp because our Western aspects of our culture is so content heavy. It's about the mechanisms of speech and the way we communicate. Whereas I try and teach our would-be practitioners that if you can actually connect with people, if you can shut up and tune in, if you can listen and look for what's going down, if you see a 14-year-old boy and you're asking about sexual health and he's suddenly interested in what's going on out the window, well, that says something. That's his communication. You've got to be watching for what's going on and listening for the deeper meaning. So I think there's relevance. We get that, I think, in Aboriginal communities from our historical connection to sign. But in a sense, it needs to be a pedagogical strategy, I would suggest, for the non-Aboriginal and Torres Strait Islander health professionals.
Well, I was just going to add that oral and non-verbal is part of who we are, and I can and while you guys were talking, I was just thinking about a time when I was up in Catherine, and I observed quite interestingly a whole conversation happening between the mob up there with the non-verbal thing, and it was like it's like we do it all the time.
Yeah, no, it does. Okay, thank you. Any other questions of the panel? Oh, now don't be shy. Nikki, oh yeah.
I have a question online.
Oh, yes.
Donna Rees, Assistant Principal Hearing Support in Dubbo, New South Wales, also a volunteer co-director of Hear Our Heart eBus project. My question is for you, Kelvin, about the eHealth for Life. Where are we at with this, with the strategy and the change of government and so forth? Just interested to hear where we're at with this program. Thank you.
It's the short answer is it's on the move. The difficult answer is that there's so many different components of that. So the eHealth for Life group is a group of interested people in eHealth, which we use a hashtag for on Twitter if you want to. And it's really just a group of people trying to get a motivation and a concerted effort to try and address some of these issues. It's very diverse, it's very eclectic, it's wonderful in the different views that we have, but at the same time it's also that when we come together we project the same kind of unity in which we're trying to move forward. There's the Medical Research Futures Fund, which is around the corner, which there's going to be hopefully a substantial amount of money for ear research, and we're trying to make a really good push for that. There's the NKPIs work that we're doing around Australia, try and get the data sets that we need appropriate. And there's also the work around some of the initiatives in delivering services to the communities in an appropriate way and look at the evidence-based policy for that. So it's a very wide group. People come in and out of that group all the time. So please feel free to get into there. And hopefully we've had change of staff within the College of Surgeons. So we've got a new person on now. So those newsletters will come out again soon. So if you're interested, get in contact with us and we can make sure you are kept in the loop.
Okay, thank you.
Thank you. Any more online? No. Yeah, Nikki.
Just as the lady mentioned this morning about Ministry of Health or LHDs don't do screening at the moment by the look of it. So there has to be a lot of gaps. So I know the Aboriginal Medical Services screening with, and some of the LHDs do screening with babies after the mum goes home, and there is some screening around the child health assessments. So where are the gaps and what can we do, or the Ministry of Health or New South Wales Health or whoever it is, around the gaps, because there's huge gaps. So I'm not sure if there's anyone from the Ministry in the room that can talk about why there isn't those assessments being done, and who can we contact and push this agenda to say, we know there's gaps, what can we do about it?
The very first thing that has to happen is that children's ears need to be looked in regularly, Aboriginal children's ears regularly, from as early in life as possible. So you need systems that encourage and support that. I know that there's a process happening at the moment, a kind of a harmonisation at the national level of the child health records, the personal child health records that parents are given. But at the moment, if you look in, for instance, the Blue Book in New South Wales, there is very little in the way of, ear checks aren't necessarily, there's no schedule for looking in ears. There's very little around questions for, so are you concerned about your child's hearing is probably the main thing that's asked. And as I was saying before, I think that's a very difficult question to answer for both the primary health people and for families. So yes, I think we need systems and processes that start with supporting primary health to look in children's ears, Aboriginal children's ears, every time they present, because ear disease is, in New South Wales, it's mostly silent. You don't see discharging ears as much as we used to, although it still happens. So that's, I think, a good starting point.
Yeah, I'll try and add to that. It's a complex answer because we need to know what works. Screening, as much as I like it, doesn't work for all populations, particularly our mob. And so right from day dot, we need to make sure on one side we're getting the 715, for example. The ear check in the 715 is, did you check the ears? Tick box, that's it. So we need some robustness around it. So there's a process at the moment, we're looking at robustness around that. There's a practice incentive programs that we're looking at as to get funding for AMSs and also general practitioners to actually encourage them to look in ears. And it might be small monetary amounts, but that helps actually get in there. We need, the workforce is small, as you said, less than 1%. So we need everyone looking in ears. The mums and bubs programs, the nurse audiometrists, nurses, GPs, ENTs, everyone needs to look in ears just as a routine. You listen to a heart, you check the ears. And then when we get all that kind of information, then we need to set that database up to capture that. At the moment, there's as I mentioned before, there's a national database being set up around the newborn hearing screening program. And our idea is that if there's a national newborn hearing, so every child in Australia is checked and put on a database, then that we should be able to put our mob onto there and follow up with whether it's 6 months, 12 months of hearing checks. And those who are picked up to be poor, we can follow. And those who are okay, then you don't worry about them. But there needs to be some kind of data set to keep that. Now, to get that data set going, it's going to cost millions. And that's the argument we're having at the moment as to how we actually get that going. But because there's a national interest in that, it can actually work well. So that's probably the short answer. And the final answer, which Sam didn't allude to, is that Hearing Australia doing some fabulous work around early years program to start looking at what is that data set we need to collect.
Yeah. Well, yeah. And I think one of the real challenges, particularly within the Aboriginal community control sector, is having the management information systems that talk to each other. We've got a whole, everybody runs their own little system, which is a big problem.
I'm Rhonda from TAFE, and I run Allied Health Program with Poche. I have a question. Why aren't we using the practitioners incentive program to help get this data? I know it only started in 2016, and like you're saying, if we're checking, children's hearts, taking the bloods, why aren't we giving the incentive and pushing the government to say, here's your incentive, we need to get data on children's hearing? It's already, the foundation is already there, and I just think that people's having heart problems, diabetes, and all this is all coming into the PIP system. Why aren't we pushing the government to say, let's add the hearing, give them an incentive, otherwise they won't do it?
practice design program is going through a massive overhaul at the moment. One of the problems, the first problem we have with the practice design program is that disease is not considered a chronic disease in Australia. And that's a huge downfall, and that's our fault in terms of our advocacy. We haven't been strong enough in doing that. The second thing then is that in that overhaul, it's trying to work out, they're trying to keep costs down because it keeps costs going up. So if you're trying to add item numbers in there, they're trying to improve that. It makes it harder. The third problem is that the practice need program does not actually get the data or the outcomes that we need, getting the wrong information. And so it's how do we actually change that to get the right information? So there's a lot of work around that at the moment to say, well, if we are looking at disease, what do we need to collect? How does that fit into the bigger picture, because we're not actually at the same chronic disease process, and then how do we incentivise that? So it's a very good question, but it's actually occurring at the moment.
Right. Question out, mate.
Hi, I'm Jeremy and I'm from National Acoustic Laboratories, and just like to say thank you to all our presenters. You covered a lot of things, very important things in a very short amount of time. If only we could just delve into each of these in greater detail, it'd be great. My question is that from where I stand, our research facility is very focused on improving the hearing healthcare of all Australians. And we could see all the initiatives that Hearing Australia and all the other programs around the world, or Australia, is tapping into dealing with Indigenous hearing health from a very early age. But my question is, how is it that we're able to use the opportunity and tap into this idea of co-designing research programs around building Indigenous hearing health? From a researcher's point of view, where do we approach that opportunity? Where do we start with co-designing using the knowledge of the cultural knowledge, and yeah, just where to start, I think. Yeah.
Look, I won't go into the technicalities of what stages of research, but I would suggest that if you're thinking of co-design, the first step is to build a relationship with that community. So it might be, look like it's even social, but in fact what you're doing is you're letting them see who you are. And if you become a trusted ally, then you can build on that. Elizabeth Harris, who's worked for UNSW out in southwestern Sydney, used to do some presentations on what the chicken money bought. And what she realised was that she started very small with Ingham's, a small grant from Ingham's, processing out past Campbelltown. And with community input over a decade, it turned into this huge study on following an cohort of Aboriginal kids throughout their life. But it was that small start. She was talking about the monetary start, but it's the same thing with the small start, with the relationship, and you become a trusted element, then the thing I would suggest starts from there.
Yeah, I was going to suggest the Australian Institute of Aboriginal and Torres Strait Islander Studies ethical guidelines. They've got some really great steps there. The Lowitja Institute has some really great resources available as well to provide you ideas around the steps to take to begin research in Aboriginal and Torres Strait Islander communities. So does the National Health and Medical Research Council of Australia have a range of guidelines in regards to ethical conduct of Aboriginal health. I mean, but I think the critical thing that you've got to remember though is when you start doing research in our communities, again, I go back to the central positioning of Indigenous knowledge as cultural ways of being and knowing. And while I put that diagram up there about system thinking, that is very much a scientific Western and approach to how you might consider complex issues as a Titus media. But critical to research is that you have to understand Indigenous research methodologies and our cultural ways of being, knowing and doing. That has to be central to a research initiative, and not that Western scientific models have to be Aboriginalised. Our knowledge is centre and first and foremost.
The two ways I'd talk to that, firstly is that we need more Aboriginal researchers. There's not enough emphasis to try and make that go through. And I think as researchers and as clinicians, we need to encourage, put forward, support encourage, nurture researchers in this space, and that's paramount. And it doesn't have to be in Aboriginal research, and that's a mistake that we make. It's about addressing the professional inequality in the research sphere. The second important thing about starting any kind of this research is understanding where you're coming from. And if you understand where you're coming from, then you can actually help that. I deal with a lot of stuff where people have right intentions, but still have no idea about it. And some people have heard me say this before. So forgive me if you've heard this before, but it's a really nice way to understand some of that kind of bias that we think about. Guys, stand up. All the guys, Dennis, all the guys in the room, stand up. So a typical day going to work, we get up, have a shower, get ready for work, slap on a bit of gear, shave if you do shave, and then look in the mirror. And how many of you sit there in the mirror and say, I look good, I want to have a great day today? Do you do that? Sit down if you don't do that. I've got the right gear on, I look all right. Yeah, pretty well. Now reverse that. All the women stand up, same thing. So same thing occurs, and you get ready. The night before you've probably chosen an outfit. You've worked out what bag you're taking. You're thinking about your shoes. You're thinking about where you're going to. And then the second process occurs where you start thinking, where am I tomorrow? Am I going to be working back late? Do I need to park close to the hospital or to the university because I'm going to be going through dark at night time? Am I going to be on a panel? Do I need to wear pants rather than skirt because I'm on a panel? Am I working near that sleazy guy that's going to be looking down my shirt? Do I need shirt, scarf? Am I around people where I feel a bit vulnerable? And it's going to be cold? Is it going to be all those kind of things? There's a whole different preset you think about, and you're thinking about dinner, kids, all these other responsibilities you have. Now sit down if you don't think like that. Okay, great, sit down. And it explains the point. And the point being is that no one in this room actually thinks they're sexist. But just in that experiment alone, all of you are sexist, whether you're female or male, about the way you think about things in a different manner. And so trying to translate into Aboriginal knowledge and Aboriginal ways of thinking is that when you're a kid and you go to a supermarket or a shopping centre and you're Aboriginal versus a non-Aboriginal kid and you see a copper, your reaction is completely different. Your adrenaline goes up, you're wondering what's going on, who's in trouble, where do I have to run to? Whereas a non-Indigenous kid is going to go, oh, I feel safe, a cop's here, it's good. And that's a whole subset of different things that we have that we don't actually appreciate when we think about this. And it's exactly the heart of research. In research, we think the same. In research, we think, I'm going to put a cochlear implant in, we want to know what the outcomes are. The community don't care about that. They want to know, is my kid going to talk? Are they going to get a job? How am I going to get the healthcare they need? How am I going to get food on the table? It's all different mindsets. So when we get that mindset right, we can actually put the research question in the right frame. When the research question is in the right frame, we'll get the whole community on board, and that makes a huge difference.
Well done. Thank you. Now, we do have one more question from an onliner.
We've actually got two questions from online, if that's okay. Do we have time?
That's great, yep.
So the first one is from John Newell from Macquarie University. He had a question for the whole panel, if they have time. They would like to get more Indigenous students into audiology and general hearing health programs at a university level. Can you as a panel give some thoughts on how this might be accomplished? They've had trouble attracting and supporting these students in their programs.
Thank you for the question, Questioner. It's a good one. We're looking very hard across the board in how you not only recruit Indigenous students into university, particularly the health disciplines, but how you retain them to graduation is the difficult area. A lot of work's been done, and I'm not an expert in this field, but a lot of work's been done around the factors in students at university. If it could be summed up in one word, it's belonging. So if the student can feel they belong, it's not an alien, it is an alien institution. It's like going to Mars. They speak this funny language, they have funny concepts and paradigms of doing things. So you break down that strangeness first. When they actually get there, they need to feel like they're welcome, they belong, the microaggressions are reduced to a tolerable level. They can see themselves in curriculum, they can see themselves in the academic staff, they can feel themselves in the processes, the Aboriginal values are there in the way the university runs. I joked to my Vice-Chancellor, I've been in my job at La Trobe only since February, and they could have asked me what I was going to do, and I said, I'm here to decolonise the academy. You know? It's a running joke between us now, but I'm serious. But it's partly that reason. If people can see themselves in this, what hitherto was an alien institution, they might come and they might stay. So I'll shut up there.
I saw a great series of tweets from Chelsea Bond this morning on Twitter on exactly on this. Yeah, on the topic of the role of Aboriginal studies units in universities, and not necessarily to be seen as ghettos, but who also have a role to play in helping the university decolonise. Hearing Australia has a relatively new scholarship program where we have 3 scholarships set up with 3 universities, and John, who's asked the question, is from Macquarie, which is one of them, for Aboriginal and Torres Strait Islander Masters of Audiology students, and we're just in the process of setting up 3 more. And so it's been going on only for 3 or 4 years, but it's very slow to take off. And understanding, one of our challenges is developing an understanding of why that is, and there are lots of very good reasons why that is. But seeing the role that Aboriginal studies units play in universities, they are absolutely vital to creating that space that you are talking about, Dennis.
I'd agree with all those things said, but I'd also say to John is you need to get the pipeline fixed. And, there are plenty of forums. I'm very proud to say that we steal most of those good candidates to medicine and to nursing, which is fabulous, because we have marketplaces, we encourage, we role model, we mentor, and we need audiology people in that space quite significantly.
Had a quick little write-up. We had before in a previous life, I was the director of the Poche Centre at Flinders University in Adelaide and Northern Territory. And through the generosity of the Poche money, we were able to set up an emergency fund. That emergency fund was for a range of things. When students found in bills they couldn't pay or had to go home for a business. And one time it was used because we had an audiology student moving on to the masters who couldn't afford the $5,000 or whatever it was for equipment to go on. So we gave them a no-cost loan, no interest loan for X number of years so they could actually progress. So the financial barriers are there as well, I would suggest.
We have one more online first, and then
one more online question from Alan from IAHA. He has no mic, so I'm his voice for the moment. Much of what's needed, he says, seems to be known and really depends on having a workforce and supports to enable that workforce to work with communities who are also supported to deliver culturally appropriate and effective care. What chance is there of being supported at research translation through MRFF, for example? Or is there some other way?
I think same as before, the MRFF is going to make a huge difference to try and get translation across the board. But I think the right question has to be asked to make sure that we get that the answer correctly dealt with. And I think that's a real challenge for us to do that. And certainly for the blinds going up and down. And certainly for the work
the little hint.
doing, we certainly encourage you to get involved in this process.
Oh. You almost want to let there be light.
Sorry, all I pressed stop on both of them and now they're both.
Now we know where it's coming from. Yeah. Okay, sorry. Yes, Linda, you had a question. Oh, just...
Sorry, Linda Lewis again. Just a little bit about what John actually said. I actually started the Masters in Clinical Audiology here, and I had to withdraw because one of the main reasons was there was a lack of support by the lecturers. They weren't available. There was only one lecturer that was supportive of the whole class. I've been doing screening for 12 years, over 12 years, and I found it very, very hard with a lot of the concepts. but I also had a lot of personal problems with my family that actually stopped me from going on. So I've had to withdraw, but I really would like to have the support from the lecturers to be a part of that. And that was at Macquarie University. And I'm not sure what it was like in Queensland University or at Flinders University, but I think the lecturers need to give the students support. I was the only Indigenous student there this year, and I did win the scholarship, but I couldn't go on with it because of what had actually happened within my family. I think the lecturers need to know those things. Within the Indigenous community, there are not just one thing, there are numerous things that go on. And I wasn't the only one that withdrew. We had 68 students start in February, and when I withdrew, I think we were down to 50 students. And that's not just laymen's, they were teachers, they were nurses, they were audiometers, that were withdrawing. So if that's not showing, excuse me, Sam, if that's not showing Macquarie University that there needs to be support there for the students, then I don't know what else will happen. So, thank you.
Thank you. And behind you, there's one quick question.
Hi, my name's Jeanette Brazel. I'm an audiologist and I teach audiometrists at TAFE. I'm just sort of going on from that and talking about training. One thing that we're pleased to see doing the Certificate 4 in Audiometry and the Diploma of Audiometry is that we're getting more and more Indigenous students, and we're lucky because we deliver online, which makes it easier for people, and they have to do clinical placement. So that's our biggest hurdle for most of our students, is finding that clinical placement, because we're online and we can, although we can provide workshops for them to come into, we'd like to see funding made available for teachers to go into communities to help the students get this level of skill, which is, you know, they're learning to do hearing testing and learning to fit hearing aids. It's not, yes, it's not the audiology level, but it can be a stepping stone. But it also helps students realise that if this is an area that they're particularly interested in, that they're on that pathway, but it's not that the massive jump into doing the Masters of Audiology. So I guess what we think would be helpful is funding in that area.
Thank you. I don't think they warrant involving the panel, although I see Sam's really keen to say that Hearing Australia is going to convene a workshop to talk about this.
I actually didn't say that. But I know this is something that we've spoken about over quite a few years. It is a real problem. It doesn't matter that it's not audiology, but it's a real problem getting supervision so that Aboriginal health workers or other audiometry students can enrol, because I understand you have to have clinical supervision in order to enrol for the course and then complete. But yeah, it's really needed, as is it would be lovely to see a pathway for Aboriginal health workers in that space.
Promo from IHA? No, go on.
Yes. I also wanted to mention that IHA, Indigenous Allied Health Australia, is there for Aboriginal and Torres Strait Allied Health students going to college, going to university and graduates. And we have a very, very good mentoring plan for our students. We have over 75% retention rate of anyone involved, students involved with IHA getting through their university degrees. So a lot of people still probably don't know about IHA. So if you've got any students or anyone that are doing allied health degree, make sure they're getting in contact with IHA, because we probably could have helped you through the things you were going through. So we're a national peak body, and that's our role. So if anyone wants contact IHA, have a look online, and we've got our conference in September in Darwin that you all should come to, that you would enjoy and learn lots about Aboriginal people and allied health. Just a bit of a plug there.
Thank you. Yes, one down the front here. Excellent. It's amazing what happens just before lunch, eh? We're half an hour over, but...
Suddenly brave. So my name's Michaela and I'm actually a new graduate of University of Sydney at the Masters of Occupational Therapy. So my interest through that study is regarding, I guess, community and population health. Specifically, I looked into conductive hearing loss as a result of otitis media. And again, although this isn't a culturally safe way of conceptualizing it, productive occupation, as in learning when in childhood, or working or resource seeking occupations for your family throughout the lifespan. I'm just interested in how, for different population groups, as someone who's just new to the New South Wales health system, with all of that in mind, because they contribute significantly to closing the gap, how can I work and be a supportive allied health practitioner to other people who are closer to the ear health issue than myself? Obviously, I understand some occupational therapy mechanisms of addressing those kinds of things, but with the context of waiting lists and all those kinds of things, how can I be a better part of the system?
I know the correct answer about being proactive. I think far too often we're reactive to a lot of the situations. I'd be certainly championing to your organisation and your body to say, what are we doing in this space? Speech pathology had this wonderful apology for Aboriginal health and how they've lacked in there and really want to push forward. And I thought it was a really powerful statement for an organisation to make. At an individual level at your workplace, I think it's really important to encourage the diversity in your workplace, but also encourage participation by Aboriginal people into the employment, but also in the gathering process, and moving away from that kind of paternalistic, tokenistic, we're going to consult, to saying, let's get some real employment into this organisation, let's get the right people in there and try and push that along, and just have a passion.
I'm not sure how to answer your question, but I can tell you that therapist on their team, Yolanda, so that might be worthwhile giving her a call and seeing what she does in that space. Oh, yes. We have this amazing conference every 2 years called Otitis Media Australia, or OMOS, and it's going to be in Western Australia, isn't it, next year? And because OM really is the population, of course, that it majorly affects is the Aboriginal and Torres Strait Islander population. So almost everyone that attends the conference is in some way interested in Aboriginal and Torres Strait Islander hearing health. And it's multidisciplinary from surgeons to speechies to health workers to Aboriginal researchers, epidemiologists. It's really fantastic. And it's not that big a conference. So in the course of 3 days, you can meet a whole lot of people that you can form connections with and spark ideas. So and people come away just reinvigorated and inspired. So that, yeah, major plug for OMOS. If you're interested in this area, it's the best conference to go to ever.
Ever. Yep. The other one I think that's important to look at is NACHO, the National Aboriginal Community Health Organisations, put out an electronic newsletter a couple of times a week. And, for anybody working in the health profession and even beyond health, they're well worth getting because they cover off on every issue dealing with Aboriginal and Torres Strait Islander health and politics. And so you can gain a lot of insight from an Aboriginal perspective on these issues by just looking at that newsletter. Well, I think I will draw it to a close. We're half hour over, but that's okay. Lunch is out there. Can I just again ask us to thank our panel, Kelvin, Sam, Dennis and Carmen. You know, it's so thought-provoking and particularly recognise those people who are online, and great to see that you haven't let the side down by asking some questions. You wouldn't be the first, we'll leave that till the next one. Online to not ask questions. But look, this session has been great. It's a topic that we've thought about for a long time. We know how important it is. It has so many more ramifications outside of health that we need to be really aware of. What we want to do, as I mentioned earlier, is put out a Poche opinion piece, which will probably take 3 or 4 weeks to compile it, and in so doing, it'll be the video plus some papers. And I wanted to just recognise our brilliant captioner, who's I'm in awe, you know, and just think, wow, this is quicker than drag and dictate could ever do. But anyhow, this is no, it is fantastic, and we really appreciate that. And again, our apologies for not having a signer here this morning, but we hadn't had anybody indicate that they needed to have a signer, otherwise we would have had one here. But this is a very important session. It's really the beginning of a conversation. We've heard about a number of conferences that are coming up over the coming years that are really well worth getting involved. Thank you for your engagement here. Thank you to Tim, who managed all of our onliners, and the Poche team Sydney, who helped. Well, not only helped, they did pull this together. And of course, Carmen and I are on the Poche Indigenous Health Network, which is a national collection of Poche centres, and we do that from this perspective, but bring these issues together. If you have an interest in an area that we haven't already covered off on, that you think that we'd like to run a forum like this in the future years, please let us know, and we will, you know, we'll try and pull together something, because these are so important, not only for today's session, but you know, into the future. And being live broadcast and also being available for students to be able to access at a future time, to be able to hear directly from, you know, a panel of experts, and of course a very thought-provoking question. So thank you. Please join us for lunch, and thank you all for your participation.